Friends, let's complete this topic. Now we will concentrate on male infertility. Just let's go through spermatogenesis. The entire process of spermatogenesis takes 74 days, and inclusive of transport and ductal system, it takes 3 months. Every day around 200 to 300 million sperms are produced, and the calculation is 4 sperms per Sertoli cells. We had seen that the cervical mucus and sperm interaction is very important. So let's see what are the changes which take place once the sperms get deposited in the cervical mucus. The mucus provides nutrition to the sperm, alkaline medium to thrive. If it would have been acidic, because of vaginal pH, most of the sperms would have died. It sieves out abnormal sperms, so only the normal sperms can go ahead. And it also causes capacitation of sperms, which takes almost 1 hour. And this capacitation is very important. That provides energy to the sperm for that forward movement and the distance which the sperm has to travel. And it also provides storage until upward propulsive movement occurs. So it also acts as a storage media for the sperms to keep them alive. Then there is acrosome reaction, where the hyaluronidase enzyme gets released that weakens the membrane and penetration occurs. And once the sperm penetrates the ovum, then the zona pellucida becomes thick, which avoids further entry of any other sperm, and thus fertilization takes place. Now, what are the factors which will lead to male infertility? It can be genetic, abnormal Y chromosome, or XXY, where there is additional X in Klinefelter syndrome. There can be disorder in spermatogenesis. Almost in 50% cases it is found due to raised scrotal temperature, especially seen in men working in furnaces, wearing very tight scrotal supports, or if there is presence of ectopic or undescended testes, then the temperature in the testes is high, thus leading to defective spermatogenesis, and the count would decrease. Again, the quality of the sperms will not be very good. Hormonal causes, pretesticular, if there is hypogonadotrophic hypogonadism. Hypothalamus, less secretion, the gonads will also secrete less hormones. Hyperprolactinemia, uncontrolled diabetes, hypothyroidism. Testicular causes, if there is any history of orchitis, may be infective from infections like mumps or TB or gonorrhea, or any trauma to the testis. Vascular, if there is torsion or varicocele present. Immunological disorders like cryptorchism. If the patient is on drugs for a longer time like calcium channel blockers, anticonvulsants, antihypertensives, spironolactones and cimetidine, that also affects spermatogenesis. Again, immotile cilia syndrome, which decreases the sperm motility, that is Cartagner's syndrome. Post-testicular causes are obstruction. The testes are forming the sperms in good quantity, but they are not getting transferred. Congenital absence of the duct or inflammatory block, maybe because of gonococcal infection or tubercular infection, will lead to obstruction. Maybe there is some surgical trauma. So we have to ask history of any surgery performed for hydrocele or hernia or varicocele before. There can be accessory gland disorders. These glands are important. Seminal vesicle, prostate, these all secretions are important. So if there is prostatitis, if there is vesiculitis, or if there is congenital absence of vas in cystic fibrosis, that will also affect the fertility. Then disorders of sperm motility, 50%. Sperm antibodies or low fructose, sperm acrosome defect, zona pellucida binding defect, zona penetration defect, and oocyte fusion defect will be the causes. Then commonly sexual dysfunction, that just the deposition of sperm is not taking place properly. Low frequency of coitus or impotence, premature ejaculation, retrograde ejaculation, hypospadias are the conditions where infertility would be caused. Bad habits, addictions in the form of smoking, alcohol, tobacco, some drugs or steroids may affect the infertility or the fertility. Unexplained, 15%. So now we will concentrate on the history in male partner and the examination. So we have to see the age of the patient, previous children in case of secondary infertility, duration of infertility, what are the contraceptives practiced, coital frequency, same as female, habits, smoking, alcohol, tobacco, drugs, any chronic disorder before and past history, any operative procedure, sexual dysfunction, and we should not forget to ask the occupation. He works where? In some chemical industries also there are effects of those chemicals getting released and the count may go down. General examination, look at the height of the man, increased in Coleman or Klinefelter syndrome due to there is late closure of epiphysis, so the height goes on increasing. Weight, underweight, undernourished, as well as obesity, hormonal disturbances. Klinefelter syndrome, you will find gynecomastia, thyroid enlargement, hirsutism. Local examination, it includes examination of penis, scrotum and surgical scar and presence of varicocele. Then there are special investigations for male factors. The commonest one is semen analysis. This investigation is very important because one investigation which costs 100 rupees can rule out 30 to 40% of the causes. So before we go for any other test which we have done before, after history and clinical examination, this should be the first investigation to be advised, which rules out almost 30 to 40% of the causes of infertility. Other investigations are like hormonal assays, testicular biopsy, immunological test, patency test for the vas, and chromosomes if required. Now let's see semen analysis in detail because it's most important. Again, there are many MCQs asked on this. What is the best specimen? It should be produced after a short period of abstinence. We have to give these instructions to the couple that the collection of the semen should be done after 3 to 5 days of abstinence because otherwise sperm concentration may be decreased. It has to be obtained by masturbation in the vicinity of the lab because condom sample cannot be accepted as it may have some spermicidal chemicals. Sample should reach to the lab within an hour. If it reaches late, maybe the motility and other factors will get affected. WHO recommendations, pH should be 7.2, volume even as low as 1.5 to 5 ml. Sperm concentration more than 20 million per ml is good enough. Very important MCQ. Adequate, 20 million and more is adequate sperm concentration. Now the latest WHO guidelines are saying more than 15 million is also sufficient. Percent motility more than 50%, latest more than 32%. Normal morphology, it was previously more than 50% normal, now it is even 4%. So these are few important things to be seen in normal semen count. Few terms, let's get acquainted with them. Aspermia means usually you feel no sperms, but remember aspermia means no semen. Absence of semen is called as aspermia. Important MCQ. Azoospermia, there are no sperms in the semen. Remember the difference. Aspermia, no semen. Azo is absence of sperm in the semen. Oligospermia, low count. Astheno, no motile sperms or diminished motility. Necrospermia, mainly dead sperms are seen. Terato, as the name suggests, abnormal morphology. Hypospermia, low volume, that is less than 1.5. Hyperspermia, more than 5.5 ml of semen. Most important factor is density of the sperm. If the count is below 20 million per ml, they are associated with infertility and we call it as oligo. But now the latest guidelines is even less than 15, then it is called as oligo. So mild, moderate and severe variety. If one report of the patient says or it is abnormal and the count is less, then can we declare him as oligospermic? No. We are supposed to give instructions to him to produce another sample maybe 1 month later or ideally 3 months later, because we know that one batch of sperm takes 74 days for formation, 3 months from ducts to come. So maybe 2 samples repeated every 3 monthly, and if they all show there is a defect, then we can say that he is azoospermic. Only after 3 negative or below average count we can call it as azoospermic or oligospermic. So please don't label the patient on basis of one particular sample. Testicular biopsy, it is indicated in azoospermia to distinguish whether it is the testicular failure, means testes are not forming the sperms, or there is some obstruction because of which the sperms are not reaching up to the semen. It's a true cut biopsy which is to be done in local anesthesia. FSH levels are very important to distinguish between testicular failure or obstruction. Instead of directly going for biopsy, we can just simply do FSH in a male and see in azoospermic male. FSH is raised in case if there is testicular failure, because again pituitary is secreting, the response is not there, so FSH levels go high. But in obstruction with vast difference, FSH level will be normal. Low FSH levels in a male, they are indicatives of pituitary or hypothalamic failure. Either gonadotrophin releasing hormone is less, or pituitary is failing to secrete this FSH. And they will have treatment with FSH or LH with GnRH. Now these few important terminologies. What is IUI? Is artificial insemination. Intrauterine insemination. It is called IUI. It can be husband semen, or in cases where there is azoospermia or necrospermia, we can also give them the option of donors intrauterine insemination. IVF means in vitro fertilization. Usually we have in vivo fertilization, that is inside the body. Fertilization which takes place outside the body is called as in vitro fertilization. ICSI, very commonly used, again MCQ. Intracytoplasmic sperm injection. In cases where there is oligospermia or there is asthenospermia, ovum is picked up, sperm tail is broken, and the sperm with the head holding is injected inside the ovum. This is called as intracytoplasmic sperm injection. It's part of IVF procedure, ICSI. GIFT means gamete intrafallopian transfer technique. MAF is micro-assisted fertilization technique. MESA means microsurgical epididymal sperm aspiration. When there is a block, we can aspirate the sperms before the block, either from the epididymis. It can be microsurgical or percutaneous epididymal aspiration, MESA and PESA. Testicular sperm aspiration, if the block is quite close to that, is called as TESA, percutaneous testicular sperm fine needle aspiration. And testicular sperm extraction is called TESE, TESE. So these are few important terminologies. Chromosomal studies are required sometimes in cases of syndromes, Klinefelters, where their chromosomes would be 47XXY, usually in azoospermic males. Immunological tests, we have seen the test during cervical factors. So if any of these tests are suggestive that there is presence of sperm antibodies in the seminal plasma, then we should go for this. The immunological factor is seen almost in 5% of the patients of male infertility. Sperm agglutination test, immobilization test, or immunoglobulin specific assays are available to detect the immunological defect in semen. ELISA and RIA determined antibodies to sperm, seminal plasma, or even to cervical secretions. Ultrasound can be used in cases of hydrocele to scan the scrotum, color Doppler to detect varicocele. Sometimes urine examination is important in cases like retrograde ejaculation, where the post-ejaculatory urine is made alkaline and centrifuge, and if there is presence of sperm, then it proves that there is retrograde ejaculation. How to manage male infertility? Educate the patient, tell the side effects of addictions to the occupation, coital position, everything, masturbation frequency, because it leads to sperm dilution, substance abuse, proper supports to be worn, proper control of diabetes, thyroid disorders, then surgical erection of varicocele, antibiotics in case of infections like orchitis, prostatitis, antioxidants like vitamin E and lycopene are helpful, then selective serotonin reuptake inhibitors, Hormonal therapy in the form of HCG, testosterone or clomiphene can also be used in males. Clomiphene 25 mg daily for 25 days followed by rest for 5 days in between. These type cycles we can give 3 to 6 cycles in cases where the motility is less or there is low sperm counts. Testosterone can also be given 25 to 50 mg daily orally to improve the testicular function. HMG can also be used. GnRH in cases of hypothalamic failure, dexamethasone, and sometimes in erectile dysfunctions we can use Viagra, that is sildenafil, which can be used for correction. Contraindicated in male on hypotensive drugs, cardiac diseases and diabetic retinopathy because it leads to penile fibrosis, infection and prolonged erection. Insemination, I told you that 0.5 ml of washed and processed semen is injected into the intrauterine cavity. It is useful in male infertility like severe hypospadias because the sperm deposition is abnormal, retrograde ejaculation where sperms are going in the urine, sexual dysfunctions, impotency, or if there is oligospermia, asthenospermia or azoospermia. In azoospermia, we go for IUID, that is intrauterine insemination of donor's semen. In female infertility, if we have cervical factors or factors like vaginismus or unexplained infertility, we can also go for controlled ovarian stimulation, ovulation monitoring, then HCG to cause the ovulation, the LH surge, and around ovulation or at the time of ovulation when on ultrasound we see, we can go for IUI H or D as per the requirement for 3 to 6 cycles. Now we'll see what are the assisted reproductive techniques. Remember, IUI is not falling, it doesn't fall in ART. ART are those where there is intervention done to retrieve the oocytes. Then only that procedure is called as ART. So in vitro fertilization and embryo transfer and the related other procedures are included in ART. Indications: in occluded or damaged fallopian tubes, ovarian failure or decreased reserve, unexplained and multifactorial infertility, endometriosis very severe, male factor infertility where the count is less than 5 million per ml, or we have tried IUI repeated cycles and they have failed, cervical hostility, therapy for the female cancers she has taken, genetic disorders. In IVF, in simple language we can say that we downregulate the HPO axis by giving GnRH agonist. There is short protocol, long protocol, there are many ways depending on the patient selection. Then there is stimulation and there would be super ovulation either with the help of clomiphene or drugs like gonadotropins, LHFSH or HMG. Once these eggs are formed in multiple numbers, then under anesthesia they are retrieved with the help of a needle. These eggs are then incubated outside. This is a very expensive procedure. It requires very specialized laboratory facilities and a skilled team work. Then these eggs, once they reach a particular stage, then sperms and egg interaction is taken place outside the body, or ICSI can be performed. Then these embryos are incubated, and once they are in the stage of getting transferred to the uterine cavity, then they are transferred in the uterine cavity, that is called as embryo transfer. Before this, once the pickup of ovum is done, then the patient is started on progesterone injections and the endometrium is prepared in such a way that it becomes congruent with the embryo growth and becomes receptive once the embryo are transferred inside the uterine cavity. Clinical pregnancy rate is almost 26%, and live birth rate means the rate of carrying a live baby home is 9 to 26% per cycle depending on different places. So it varies from 10 to 30%. Ectopic pregnancy is very common. around 6%. This may be because of the factors pre-existing tubal damages, or maybe because multiple embryo gets transferred, because we just don't transfer one single embryo, multiple embryos are transferred. So maybe that leads to ectopic formation. Retrograde migration to the tubes may happen. Maternal complications are like OHSS, risk of anesthesia, or maybe damage to the other organs during pickup. Some technical terms. Cryopreservation, you have one MCQ on this. It is always done with liquid nitrogen. Oocyte donation, in which oocytes are donated if the female is incapable of producing it, maybe in ovarian failure. Embryo donation, as the term itself explains. Gift, I have told you, gamete intrafallopian transfer. ZIFT is zygote intrafallopian transfer. ICSI is intracytoplasmic sperm injection. Post means peritoneal oocyte and sperm transfer. SUSI is subzonal insemination. And surrogacy. So if the female is just incapable of bearing the baby, maybe because of ovarian failure or maybe because of uterine causes somewhere, that she doesn't have a uterus, or the uterus is too hypoplastic, or it is damaged, or some other reasons, then we can use her own relative or some other woman's womb to grow their baby, which is genetically of that couple, but the embryo is transferred in someone else's uterus where the mother is not the genetic mother. So this is called as surrogacy. So this finishes with the big topic, that is infertility. Thank you very much.